Service to Africa. And we have certain media partners who are joining us. We have the Otaibor TV. We have the Obra TV also from USA. We have the Yonkudo Radio from Canada, as well as Radio Ghana, Italy. And if you can also join us on Facebook and also on YouTube. For everyone that is joining us this afternoon, we are grateful that you are here. Today, as we all know, this month is the month of breast awareness. It's called Breast Cancer Awareness Month, and by God's grace, we have wonderful panelists here who would be sharing their wisdom and their experience in the area of breast cancer. Fortunately for us, there will be two of us who will be coordinating this, who will be moderating this. I have my co-moderator in person of Dr. Nathaniel Ej Tremer, who will be joining me to moderate this program. But before we start anything, I would want to ask Pastor Seth Preku to lead us in prayer.
Shall we pray? Our Father in heaven, we thank you so much for this time. We are praying that all our family members and friends that we have invited, who we want them to join us in this very important discussion, you would prompt them that it is time and we are waiting for them. We also want to pray for our panelists as you will give them wisdom so that they will be able to navigate us through this cancer awareness issue. And so we can also from here be propagating the message to those who couldn't hear this important message. We pray that you will be with us and guide us through this discussion. In Jesus' name we pray. Amen.
Amen. Amen. Pastor Seth Preku is the Secretary of the United Service to Africa Council, and also he's a member of the Riverside Ghanaian SDA Church. Once again, I'll just like to welcome all of you. Today's topic is breast cancer, fighting the fight, seeking the cure, and living the life. We are privileged and honored to have many wonderful, experienced panelists, and I'm so happy because by coincidence, it happens to be that all of them are women. We are so happy to have all of you here. I'm going to hand over to my co-moderator, who is going to introduce our panelists to us. Dr. Nate.
Right, thank you so much, Elder Kelson. We yet again have an opportunity to discuss a very important issue of public health concern and also of very serious concern as far as cancer and also in terms of where we find ourselves, our race, our environment and everything is concerned. So I am happy to have these wonderful panelists to lead the discussion. And the first on my list is Dr. Cynthia Owusu. Dr. Cynthia Owusu is an associate. So she also holds a master's in epidemiology degree from the Boston University School of Public Health. She joined Case Western University School of Medicine in 2006. In addition to her clinical practice in breast cancer at the Seidman Cancer Center, Dr. Owusu also her research focuses on health outcomes and cancer health disparities. Dr. Owusu is currently the principal investigator on a $2.8 million research grant awarded by the National Institute on Minority Health and Disparities. Her study is examining the impact of exercise on functional status, body composition, and biomarkers of breast cancer prognosis among African American and socially disadvantaged breast cancer survivors. Dr. Owusu is married with 2 sons. It's such a privilege to have such a woman with wealth of knowledge and experience to come and share with us today. So I will let Dr. Elder Kelson Safo continue with it.
Okay, and Cynthia, can you just wave so that people can see who we are talking about? Yes, yes. Those of you who can see us live on Facebook, on YouTube, who are here on the Zoom platform, you can see her. You're welcome. The next person I'll be introducing is Dr. Susan Montgomery. She's a social behavioral epidemiologist with a focus on hard to access underserved populations on issues of health disparities from a behavioral health and prevention research perspective. She's a translational researcher and has been a principal investigator and co-investigator of NIH CDC extensive experience in conducting community-based translational participatory research and evaluations, advocating for translational and applying research findings to the community level. She has published over 120 peer-reviewed articles concerning mental health, HIV/AIDS, and alcohol and tobacco use. And she regularly serves as a reviewer of NIH, CDC, and several national peer review journals. Dr. Susan, you're most welcome.
Right, the next person I will introduce, she has a 26, more than that, experience as a medical doctor in Ghana. When you mention her name, I think everyone in Ghana who has at least listened to the radio or television should have heard about her. She is very instrumental in terms of breast cancer promotion, breast cancer management, surgeon, consultant, and she has been at the helm of breast cancer management in Ghana for the past several years. She's had a very wide training scope. She did her medical school in Zaporizhzhia Medical University in 1989. I think this information, I had to dig very deep to really find this information. And it's really nice to have her to share her wealth of experience. After her medical degree, she went on further to work at Konfo-Anokye Teaching Hospital and entered into a residency program there. And she did her residency in surgery. And when I found out that she specialized in general surgery at the Moscow Medical Academy, and she followed this with a PhD. And I think this made her quite have that worth of experience as one of the leading female general surgeons in the country. She majored in breast surgery and also breast cancer management, ultrasonography, and oncology. As we speak, she is a consultant breast surgeon. She's also the chief executive officer of Peace and Love Hospitals, I think both in Accra and Kumasi. She is the president and founder of Breast Care International. She is also a former member of the ethics committee of the IARC. She is again the chairperson of the Ghana Cancer Board and also medical advisory board member, Direct Relief. She is a member of UICC. She is an executive committee member of IBCN. She is also the chairperson of Ghana NCD Alliance and race chair Susan G. Coleman, Ghana Race for the Cure. She's also chair for BCI, Ghana Walk for the Cure. She has so much knowledge in terms of breast cancer promotion, breast cancer management, breast cancer treatment, and we are going to benefit from a wealth of knowledge today. You are welcome, Dr. Wiafia Dai.
Thank you so much. Thank you for the warm introduction.
Thank you.
I'm humbled.
Okay, another giant person that we have in the room is Madam Petrida Peterson. She happens to be a cancer outreach coordinator at University Hospital, Saidman Cancer Center with a tireless commitment to improving health outcomes among Black and African American communities. She has over 20 years experience as a breast cancer health educator. She recently, most recently returned from the country of Guyana in South America, where she spent over 3 weeks teaching over 400 women in the villages on breast health awareness and HIV/AIDS awareness. Petrina Peterson is a well sought after conference speaker, so we are fortunate to have her here. She's a lecturer and a workshop facilitator. Ms. Peterson's award-winning communication skills and personal testimony makes her a wonderful complement to the empowerment of the health needs of all women. Ms. Peterson is an ordained and licensed minister. What a privilege. She is currently serving at Elizabeth Baptist Church, where Reverend Richard Gibson is her pastor. You're most welcome.
The last person to introduce, but definitely not the least, because she is a very strong woman. She is in the person of Mrs. Zelma Draper Brown. She is a lifelong Cleveland resident. She grew up in the Glenville area and is a proud graduate of Glenville High School. She attended the University of Pittsburgh and received a Bachelor of Science in Psychology and Black Studies, and subsequently earned a master's degree in child development. Zelma has worked over 30 years in the human service field, 22 years in juvenile justice, and over 20 years in child welfare. She retired from Cuyahoga County in 2009 and is currently working as a foster parent recruiter for SAFY, Specialized Alternatives for Families and Youth, a foster care, adoption, family, and child welfare agency. So Zelma is a cradle roll member of Antioch Baptist Church. And despite having grown up in the church, attending Sunday school and junior church, she came to know that she knows that her salvation is sure on November the 3rd, 1990. After attending missionary training at Cedarville College of Child Evangelism Fellowship, an international organization to evangelize children, she has used those methods to teach and reach children and adults wherever she goes. God allowed Zelma to attend the All-African Child Evangelism Fellowship Conference, celebrating 80 years of ministry in Ghana in 2018. So she's been back to the homeland. Her team was blessed to minister to the children in Accra, Ghana after the conference. She states, "It is so wonderful to see and know that God's word is being fulfilled in reaching the far corners of the earth. We in America can do so much to reach thousands of children around the world with the resources we have." And I think she's a person of her word, and that's why she's elected to share her great story, her story about survival, her story about living with breast cancer. And we know she will be a blessing to us. Zelma was diagnosed with breast cancer on October 1st, 2018, and now considers herself as a thriver more than a survivor. She had her treatment at University Hospital's Seidman Cancer Center, where she underwent a lumpectomy. Not many people can withstand even one of those treatments. Zelma has been a participant in paid trials for breast cancer survivors and encourages other women of color to do as well. Zelma calls herself a thriver also due to going through her journey of breast cancer, as her husband was diagnosed with pancreatic cancer 3 months later. We are blessed to have Mrs. Zelma Draper Brown in our midst. Can you wave for us? And you are very much welcome.
You're welcome. Thank you all once again. Once again, I'm just going to welcome those who are joining us. We are, today we are having the third of our series, but fortunately, because this month is Breast Cancer Awareness Month, we are dealing with the breast cancer topic, and our topic for today, or our theme for today, is breast cancer, fighting the fight, seeking the cure, and living the life. and we have wonderful panelists who are here to join us today. I'd want Dr. Nate to start with the questions. But before then, I'd want to urge those who are joining us, if you have any question, please feel free to send it through the chat. If you're on Facebook, you can also send it through the chat. On YouTube, you can do the same. We have people who are monitoring it, and they'll be able to pass your questions to us, and we'll be able to ask the panelists on your behalf. Thank you very much.
Thank you. Thank you all again. So we've been talking about COVID. COVID has been in the airways for all these times since it was first diagnosed here in the United States. However, October is Breast Cancer Awareness Month, and we can't ignore the importance of sounding the caution, talking about making many people aware of this breast cancer disease. Breast cancer is the second most common cancer among women in the United States. Some kinds of skin cancer are the most common ones. For every 8 women in the US, 1 will be diagnosed with breast cancer during her lifetime. This is the statistics we have in Ghana. We want Dr. Wiafe Adai to just tell us if we know of any statistics in Ghana that we can add on to serve as a foundation for the discussion we are going to have. So, Dr. Wiafe Adai, how is Ghana looking in terms of breast cancer statistics?
Doctor, please, you are still on mute.
I'm sorry. So let me first thank the organizers for having me during this very important month. I also want to thank all the friends that I've met on this platform. And I also want to greet my kid brother, Professor Seth Wiafe at Loma Linda University with the wife, Beatrice. I want to greet all the members on this platform. Breast cancer in Ghana. I heard you talk about COVID-19. And what we are saying is that COVID-19 did not come to stop breast cancer. It rather came to worsen an already bad situation that we have as far as breast cancer is concerned. In Ghana, according to Globocan, since 2018, about 4,650 women with breast cancer and about 1,800 died. We anticipate that this year we are going to have more women die, more than the 1,800, because of the effect of COVID-19 has been kind of bringing to us. Breast cancer is the leading cause of cancer deaths among Ghanaian women. And the median age is 49 years. And you can compare it to the median age among the Caucasians. This shows that majority of our patients are young, and most of them are below the age of 50, and that is worrisome. It makes breast cancer not only a public health concern, but also a developmental issue. But unfortunately, about 6 reports late with advanced stage disease. And the time to presentation is about 10 months. So this is because the disease is surrounded by myths and misconceptions. It's caused by witchcraft, it's a spiritual disease, it's an incurable disease. So by the time the woman roams and roams before she gets to the hospital, it's about 10 months. And I mean, the precious time is waste on going from one place to the other. So the picture, the breast cancer picture, is not good. And as we move on, I hope we will delve deeper into some of the issues that we are confronted with.
Most definitely.
Thank you.
Most definitely. Thank you so much, for that insight. And I think it's very revealing to know that the age is much lower than we are kind of used to here in the West. But we'll delve more into the demographics and all the other important risk factors as well. Brother Kelton?
Yeah. During the introduction, my co-moderator was able to introduce to us a powerful woman. We call her a powerful woman because she's a survivor. And today we are privileged that she's here with us, and we would want to ask her to share her story with us. But we want her to just give us a tidbit of how it was. To Mrs. Zelma Draper Brown, I want you to walk us through how you were diagnosed and what your reaction was when you received the news of your diagnosis. Just how you were diagnosed and what your reaction was when you received the diagnosis.
Thank you for having me. I was diagnosed after having, I had previous mammograms, and I had learned that I had dense breasts. And so I've come to find out and know that when you have dense breasts, sometimes it's hard for a small tumor to be recognized. And I had a previous, so then because I had dense breasts, the University Hospital, where Dr. Owusu is on staff, they were requiring that I do mammograms every 6 months. So I had a biopsy previously, and nothing was found. And then in September of 2018, I had another biopsy, and then I got the call on October 1st, which is the first day of Breast Cancer Awareness Month, that it was cancerous. And as you stated in my introduction, it was pretty tough because my husband had just been diagnosed in July with pancreatic cancer. And so the hardest part really was the fact that my daughter was going to have to care for both of her parents. And my husband was extremely sick from the time he was diagnosed in July. And so then with my diagnosis, of course, I was pretty reluctant to tell my daughter that I had been diagnosed as well. So imagine my surprise, since you stated that I had just come from Ghana in April. And so imagine my surprise when I met Dr. Owusu, and she's from Ghana, and that did make me feel actually a little more comfortable, because I felt that she would be looking out for my best interest. And the other thing was, when I found out she was I was satisfied with how the hospital has cared for me, and really just being very grateful, because it was very distressing to just hear the statistics. And that was something that I had really wondered about. So now I know the statistics of how things are in Ghana.
Thank you so much. To be honest, we cannot really put ourselves in your shoes, but we know it must have been devastating, especially hearing from you that it wasn't just you, your husband too had just gone through the same. But we are happy and grateful that today you're here to be able to share your testimony and experience, and I know this is also going to lift others who are probably going through similar situations. Thank you so much. We are going to definitely come back to you to hear more of it. But for now, Dr. Cynthia, I have a question that I want to ask. What should a woman who finds a lump in her breast do? A woman who finds a lump in her breast, what should be the first thing that such a woman does? Dr. Cynthia.
Yes, okay. So I also want to thank the organizers of this wonderful breast cancer awareness program for putting this together, and I pray that we can do this more often, particularly for our Ghanaian population, given the statistics we just heard from Dr. Wiafe. I will go on to your question very shortly, but I want to respond briefly to what's happening in the US. So she mentioned that in a year, about 4,500 women are diagnosed with breast cancer in Ghana. In the US, in 2020, it's expected that about 270,000 women will be diagnosed with breast cancer. That about 1,800 women are expected to die from breast cancer each year. In the United States, out of the 270,000, about 42,000 die from breast cancer each year. So the moment she mentioned those statistics, I did a little arithmetic as I was in Ghana versus what proportion are dying here. And it is a whopping 40% of the women who are diagnosed with breast cancer in Ghana who die from it. When you look at our statistics here, it is 15%. And so the question is, when the women in Ghana who have breast cancer, and I think that's a topic for discussion later. So now back to your question, what should a woman who feels a lump in her breast do? I would say don't even wait to feel a lump. That's what breast cancer screening is all about. If you follow the guidelines, then our hope is you don't even feel a lump. We detect it when it is very, very small, so that your cure, once it's detected that early, is almost negligible or very low. However, if you do feel a lump, and for some women it comes up very quickly, if you feel a lump, the first thing you ought to do if you have a primary care provider is to contact your primary care provider. Unfortunately, a lot of the underserved women who are underinsured or have no, Miss Petrina does, and she will speak to it. So if you don't have a PCP, then it means that you are looking for clinics that will let women come in and do a mammogram, because that is what you need at that point. You have a lump in your breast, you need to undergo what we call a diagnostic mammogram, get a biopsy, and with that biopsy, see a surgeon. So if you have a PCP, a gynecologist, these are physicians who can quickly order a mammogram for you and set you up with an appointment to see that surgeon. So that surgeon tends to be the first stop. So there's usually a very close relationship within any institution between breast imaging, where they do all these mammograms and additional tests. There's usually a close relationship between them and the breast surgeons, because as soon as they see a mass, it needs to be biopsied and you need to be sent off to the surgeon. Like I said, if you don't have a primary care physician, almost every area will have clinics or facilities where women who are underinsured can quickly get the breast imaging that they need. In our hospital, for instance, and I'll leave Petrina to give more details, in our hospital, for instance, so some of the work that Petrina does is to navigate these women who don't have primary care physicians to get into the breast center, get their imaging, and go off to the surgeon. So that's what you need to do. When you feel a lump, you need to get breast imaging and get your biopsy done. But don't wait till you feel a lump. Do your screening as per the current guidelines, and I'm sure we'll talk about that too.
most definitely we'll be talking about the screening guidelines, and we'll be going through all those things. Thank you so much for such insights. And we will still come to you, Dr. Owusu. So Black women and white women get breast cancer at about the same rate. But the statistics show that Black women die from breast cancer at a higher rate than white women. It's estimated that about 5 to 10% of breast cancers are linked to gene mutations passed through generations of a family or something close to that. Can you speak to these statistics? And is there anything in our genes, the Black race, that makes us more likely to have the worst form of breast cancer?
Dr. Cynthia, I still to you.
Okay, so okay, thank you very much for that question. Yes, so there's something called the breast cancer gene, which normally what it does is that it is supposed to help the genes that we have, and genes are like the brain of the cell. It's supposed to help the genes of the breast cells so that they grow proportionally, not out of control. For some reason, and a variety of reasons, the gene can go into or become mutated, it becomes abnormal, and it's no longer able to program the breast cells as it should. Now, it is hereditary, so 10% of all breast cancers will have what we call the BRCA gene mutation. So it is not that common. However, it has been found to be common in certain groups. And one of those groups is one of the most, I'll say the most aggressive form of breast cancer called triple negative breast cancer. And so generally, women who have triple negative breast cancer, as many as 30% of them would carry this gene. Okay, you compare that with a white woman. Generally, in a white woman, the incidence is 10%. So that's like a 3-fold increase in triple negative breast cancer. Now, who gets triple negative breast cancer? Unfortunately, it happens more often in African American women having more aggressive breast cancer. However, there's a lot of research going on in that area, and the belief is that all of that aggressiveness cannot be solely attributed to the BRCA gene and its association with triple negative breast cancer. Because when you exclude that, when you take European women who have triple negative breast cancer and take African American women who have triple negative breast cancer, that African American woman is still more likely to die from breast cancer than the European woman who had triple negative breast cancer. So in a nutshell, genes are part of the story. The BRCA gene is part of the story, but there is more to it than just hereditary breast cancer. Remember, it's only 10% of all breast cancers that are hereditary, although it's more represented in African Americans. And the jury is still out there as to what the additional molecular or genetic reasons for that is. The answer is not very clear.
Thank you.
I'll add that some of the reasons why African Americans are more likely to die from breast cancer is a whole host of other things. They are underinsured, so they present late. By the time they come, they are stage 3, they are stage 4. When you're stage 4, your breast cancer is no longer curable. So there's a lot of socioeconomic status underpinnings as to why African Americans do not do as well as their counterparts.
Yeah, thank you so much. And that we all know that the genes play a role, as Dr. Cynthia Owusu eloquently said, like 10%. So there is still other causes beyond that we are still trying to find out. So, Dr. Montgomery, what are the public health insights that explain the phenomenon where we have very...
Thank you, and thank you for having me on this panel. It's a wonderful panel, and I thank you for this opportunity. Yes, so when we look at the statistics that says that only about 10% and a little more for Black women is attributable to genetic makeup, we have to look at what is happening in our environment. And there's this field, this growing field in public health and medicine that's called social determinants of health. And when we talk about social determinants of health, we say that environment, the larger environment matters. Our lives, what we eat, what we live, where we live matters. And I want to kind of go back to your very first session that you had with men and prostate cancer, because the pattern is very similar. And the common denominator is that African Americans, and actually Africans in Africa, are more likely to actually present with this illness, and in the United States have very similar patterns of risk. And I think the social determinants of health, a few of them, Dr. Viafe and Dr. Cynthia have already mentioned. Access is one of them, but I'm at Loma Linda University, and in San Bernardino County, we have done a lot of outreach to Black women, African American women, and about 89% of Black women in San Bernardino County have done mammographies. So we've done a really good job getting the word out, and access is an issue, and it definitely remains an issue, better than men, I think, about taking care of the prevention aspect. So a lot of these African American women are actually quite active in seeking care. The important part is to do it regularly, not just once, but to do it regularly. Other things that we know are related are alcohol intake, tobacco intake, and then the really important ones are obesity, weight, healthy eating, exercise, and kind of the whole package. So when you look further into, I'm also a co-investigator on the Adventist Health Study, meat eating is actually a risk factor as well. But I think what I want to draw attention to, more than the things that I just listed, which is tobacco, alcohol, weight, healthy eating, these are critical issues, in addition to screening and having a regular care provider and having access to care. There is something that all Black Americans share, and I always say this is also true for immigrants, African immigrants that come to this country. I think that life for Black Americans are very stressful, and a life exposure to stress has consequences. So we find increasingly that the environment, the stressful environment which we engage with, the active dealing with the onslaught of little insults and big insults, little barriers and large barriers, actually contribute to health, and we do know they do contribute to health. So it's a complex issue. We also know that African Americans tend to be lower income. Therefore, they live in areas that have higher burdens of environmental exposure. And then I want to talk maybe later a little bit more about why I was drawn into this issue of breast cancer, because a local group of women came to me and said, "You're at Loma Linda, you do this kind of work. Why tell us? We've heard that having hair products that we use make us sick. Can we look at this together?" And there's increasing evidence that what we put on our hair to manage our hair, and especially for Black women to manage their hair, actually puts them at higher risk for breast cancer as well.
Thank you so much, Dr. Susan. Still on this issue of factors, studies have shown that social determinants, as you have said, such as poverty, lack of education, neighborhood disadvantage, residential segregation by race, racial discrimination, lack of support, social isolation, they all play an important role when it comes to the issue of breast cancer at diagnosis and survival level. Dr. Cynthia Owusu, coming back to you, can you speak to other risk factors that predispose a woman to having breast cancer?
Okay. Yes. There are a number of them, and a lot of them are related to hormones, the hormonal environment within a woman. So what's happening in the body naturally, and also what you put in your body that might increase hormones. And so what I mean by that, what do I mean by that? What I mean by that is that it's been shown that if you menstruate early, the earlier you menstruate, and the later you go into menopause, it's a risk factor for breast cancer. And that is because the longer you are exposed to estrogen, because having your menses and having your periods is related to a higher level of estrogen. So when you think about it that way, there are a number of things that you can pinpoint, and those have been established as risk factors for breast cancer. If you've never had children, unfortunately, it means that you've had a longer time of having menses one period after the other, because once you are pregnant, you don't have periods. So unfortunately, a woman who has never had a child is more likely to have breast cancer. If you breastfeed during that period, it delays the return of your period. So a woman who breastfeeds is actually protected from breast cancer. In fact, one of the reasons why it is believed breast cancer survival is improving. And one of the reasons is thought to be the fact that we are no longer giving what we call hormone replacement therapy. Years back, if you went into menopause and you went to your doctor and you complained about menopause symptoms, they would give you this medication which would replace the estrogen that you are no longer making. Yes, move forward several years, it turns out it causes breast cancer. So these are all things that increase your risk of breast cancer. Having a breast lump which is not cancerous, a number of them increases your risk for getting breast cancer. In fact, most of the time, if you have a breast lump, about 75% of these lumps are going to end up being benign, non-cancerous. A number of them will increase your risk of breast cancer. And your doctor will tell you which, and your doctor will counsel you as to whether you need to take any extra steps. Essentially, all these risk factors have been put into a model, and several models, and one of the most commonly used models is called the Gale model. And so if you are concerned about having an increased risk of breast cancer, when you see your surgeon, or sometimes you might see a geneticist, they will plug all these risk factors into that model, and there are defined cutoffs. And if you meet a certain criteria, they will tell you and they will counsel you about preventive measures that you take. So yes, there are other factors, hormonal factors, having a history of lump in your breast. Family history is critical. Family history, if you have several family members, or even one or two family members who got breast cancer at a younger age, say below 50, that is a red flag. We will send you for genetic testing. We will send you to the geneticist, because a young woman shouldn't have breast cancer, at least in the US. Our average age is 62. So if you are young, 50 years is the cutoff. We would send you for genetic testing. So family history is another risk factor as well. And there are a few more, but I think I'll stop here so others too can
Thank you very, very much. Dr. Wiafi Adai, with regards to Ghana, specific to Ghana, are there any other risk factors that you can say are peculiar to Ghana that predisposes a woman to having breast cancer? And we would also want to know, are you seeing breast cancer more in a certain region or a certain educational status or social stature? Is there a disparity between maybe Central Region, Greater Accra Region? Is there, or is it across board? I believe you are still on mute. Is she there? Okay, I think Dr. Wiafi, I can't seem to find her.
I dropped.
Okay.
I dropped, but I'm back.
Okay. Please, did you hear my question, or should I take it again?
Yes. No,
Okay.
I heard your question.
Okay. All right.
Thank you. So, when we talk about risk factors, they seem to be common across the globe. But we did the Ghana Breast Health Study with the National
Yes, you're back. Aha.
I'm sorry. Yeah, I dropped again. I don't know what's happening today. Anyway, so from the Ghana Breast Health Study, which was a 3-site study between Komfo-Anokye Teaching Hospital, Korle Bu Teaching Hospital, and the Peace and Love Hospital. Apart from the common denominators, we came out with some 2 risk factors: the use of skin lightening creams and the use of hair relaxers. So these were the 2 new things that emerged from the Ghana Breast Health Study. And I want to here thank the NCI for helping us do this research. We need to do a lot of research, but we are not doing them as we should. So that is what we found. As far as the risk factors are concerned, can you give me your second question?
Yeah, I was asking that, is it, does it have to do with educational background, social status, or region? Is it regional? You find more in maybe Central Region or Accra?
Yeah, this is one of the things we need to research on. We have been experiencing higher incidences in the Eastern Region, the Sefi area, and some of the mining areas. But we are yet to do some serious research into this and to find out even the reason.
Okay, I think we're just going to go on to the next question. When Dr. Wiafi joins us, she'll be able to continue. So, Dr. Nate, you can go on to the next question.
Yeah, thank you very much. Yeah, she was really giving a very insightful statistics concerning the distribution and all the other factors. And I think Dr. Montgomery also mentioned the hair products. So we will come to that, the details of that once she gets on board. But let's get into prevention and screening. I think when Dr. Cynthia Osu was talking, she mentioned mammogram. So far, the only breast cancer screening method that has proved to be effective is mammography screening. And we know the screening is very expensive. Therefore, it's mostly done routinely in the developed world and people with insurance. We want Ms. Petrina Peterson to help us, because one of the challenges that people of color face is the lack of health insurance, which gets them to not be able to have mammogram. So can you help us with resources that you know as to where people who don't have these insurances and people who are poor cannot afford it, where they can go for mammogram?
Yes, thank you. And I'd like to thank the organizers also for having me here today, and also especially Dr. Wilson. We've worked together with the Seventh-day Adventist Church here in Cleveland, providing breast cancer. So I'd like to thank you personally. All over that, have a chance to talk to you. You were asking about resources. Here in Cleveland, we would struggle for resources, but we were able to write grants from several different places here in the United States that would give us the money so to make sure that we have places for women to go to get a mammogram done without any insurance. We also, years ago, lobbied our U.S. Congress to eradicate breast cancer. So we have that here in the United States, that any woman who does not have insurance who's diagnosed with breast cancer, there's some eligibility that they need to go through that they can get on breast years. So after going to Washington several years in a row, several times a year, the bill was finally passed. So it's been almost 10 or 12 years. You have something to fall back on, but when you work with grants, you know also that money can run out. Right now, we do have a grant at UH where if someone comes in, they do not have any insurance. Also, we're the only hospital in Cleveland that will take women who are not U.S. citizens. Wonderful thing also. So we've been able to reach out continent natives to make sure that they did get in for their mammogram and for treatment. The particular grant that I have right now, we not only do your mammogram, but you see that there is something wrong, and you do need a biopsy. We pay for everything, down to the hospital visit, to the doctor's visit, to pathology report. We pay for all those things out of the grant, which sometimes can cost us about $10,000 in one day with one woman. But that way she doesn't fall through the loop. If we do find the breast cancer, then we do immediately put them on breast cancer Medicaid, or what we have through the federal government called the HCAP program, and that will sustain them. With the HCAP, it's only for 6 months, so we try and get everything done in 6 months that they need. If it's augmentation, if it's radiation, if it's reconstruction, it's just the 5 years of Medicaid, and their total health. So when Dr. Wilson asked me about resources, I didn't want to talk too much about resources in Cleveland available in California. So I dug a little bit for you, and I'll be happy to share these resources electronically with Brother Kelson, and also Dr. Montgomery. She probably is familiar with some of them also. So I did find in the area a grantee from Susan G. Komen called Breast Cancer Solution, and I have her grant, and it's right there in Komen in your area. As every woman counts, and it's 8 members for them also, and they provide free mammograms at the regions in your area. The Rancho Cucamonga site, they're offering mammograms in here for the low price of $49.95. And so the Upland hospital, and they also offer 95. They are not free. Maybe there can be some type of fundraiser that you can have in that area. And also, I have the number for Susan G. Komen there in that area, and Nicolette is the person that they can call. So it can be worked out, even in California. Try and work it out here in Ohio, that no one should be able to go with mammogram. Hopefully, with those reasons I pass on to your church there in California, they can tap into those things. The biggest thing that we see here to get women to go, even with services, it's not transportation in Cleveland, Ohio. The biggest thing is the fear. What do I do if they find breast cancer? So therefore, we have our social workers and navigate them through the system so that they are not worried just to come in for the screening. But we do advocate this count and throughout the city that you need to screen and get the screening on time. And just one last thing before I get off of this particular thing. One of the things that Dr. Owusu was speaking of, also, not only do they need to, if they see a lump, try and get the screening done, also look at your breast, women, because sometimes it presents as a rash, sometimes it presents as a dimple, sometimes it presents back into the body. Those are all telltale cancers of something that's going on. You have to get a biopsy. But cancer indication. So no. Something to your washing detergent. If you haven't changed your deodorant, things like that. All of a sudden, a rash comes up around you, which is what you call your physician. If you have a physician, or speak out one of those places. Screening, mammogram at low cost or either free.
Thank you very much, Ms. Peterson, for such information. I think at the point your line was breaking, so it was a little bit difficult to hear you. But I think the message was put across that we have resources. We can find them whichever state we are, and I think the organizers will make these resources available. We will give the links and phone numbers and other resources that will help people to be able to navigate some of these issues, and that money shouldn't be a barrier, a strong barrier that will make you not want to get a mammogram. So on that note, I just want to bring in Dr. Owusu again. We are talking about mammogram, and we want to know, because it's a very important tool, screening tool, we want to know first who should get a mammogram. Are there any specific people who need a mammogram, and at what times do they need it?
Okay, so thank you very much for that question. There are a number of different organizations who make recommendations, but one of the more established ones that we use in oncology is the American Cancer Society. So I'm going to tell you what their recommendations are. First, any woman between the age of 40 to 44 years should get at least one mammogram. That establishes your baseline. Between the ages of 45 to 50 years, to 55 years, you ought to get a mammogram every year. Okay, so get your baseline between age 40 to 44. After that, get a mammogram every year. After age 55, depending on your physician and your preference, you could either get a mammogram every year or every 2 years. That is okay. And when should you stop doing a mammogram? Traditionally, the cutoff was placed at age 75 years, but now they've refined it a little bit. If you have at least 10 or more years of life expectancy, which becomes difficult to determine, but if you have at least 10 years of life expectancy left, you should still have a mammogram. So essentially, start at age 40, get your baseline. From age 44, at least get a mammogram every year, and then a lot of physicians will cut it off at age 75, but if you're healthy and strong, you don't have a lot of medical problems, you could keep going after age 75. So this is the basic guidelines, but there are some exceptions to this, depending on whether your risk is deemed to be high, otherwise known as carrying the breast cancer gene. That is an entirely different story where mammograms need to start at age 30, and you have to, it shouldn't just be a mammogram, you should have an MRI as well. And so what you end up seeing is that the patient gets an MRI every year and a mammogram every year as well, but it is integrated. So every 6 months, that individual is getting some breast imaging. You get, for instance, if you start off in January with a mammogram, in July, your physician will order an MRI, and then in the next January will be a mammogram. So it's every other. So screening for people who carry a higher risk is different. It is more intensive. And then another thing I will add about mammograms is that there are women who have what we call dense breast tissue. Dense breast tissue where they have more a particular kind of tissue called connective tissue within the breast. It hides masses when they do mammograms, so it can be missed easily. If you have dense breast tissue, you should advocate with your physician to get at least what we call the 3D, the three-dimensional mammogram, as opposed to the traditional 2D mammograms. Some insurance companies might give you pushback, but that is disappearing, and insurance companies are now a little bit more accepting of the 3D mammogram. Occasionally, the radiologist might say your breast is so dense that your screening should be done with an MRI. That should come from the radiologist. If you get up and go and do an MRI instead of a mammogram, insurance will not cover it. But so these are subtle differences, yes.
Yeah, thank you so much. I think this is an important message for all of us to know, and then to kind of push our wives, our sisters to get these mammograms done. One of the things that come up always when you talk about mammogram is the dangers. So I was reading about a study, and they said it will take 1,300 women to be screened annually for 10 years with a mammogram to prevent one death from breast cancer. So some people who are against mammogram use some of these statistics to push people or scare people away because of the dangers involved in having mammogram and then the benefits. So can you tell us, Dr. Owusu, what are the dangers first, and if there are these dangers, do you still recommend it in spite of these dangers? I.e., are we talking about risk benefits, and what would be your take on that?
I recommend it 100%. Breast cancer death rates have dropped significantly in recent times because of early screening. Like you rightly said, in everything that we do, Tylenol, if you look at the side effects of Tylenol, you might never take a Tylenol. Everything is about weighing the risk and the benefit. The amount of radiation you get through mammogram is very, very little. Yet, remember what we just said, breast cancer is the second leading cause of cancer, and it kills 42,000 women every year. That is real. And if you're an African American woman, you are going to be 40% more likely to die of breast cancer. And so don't wait for that to happen. Don't get concerned about the very little radiation that you can get from a mammogram because of radiation from mammogram. Yes, there's a little risk from any and all radiation that we get, but it is negligible compared to the ramification of getting breast cancer. And so women, go out there and get your mammogram and don't look back.
Thank you very much. Dr. Yafada is on. We want to bring in Ghana and what we are doing in terms of mammogram as well. Because it's a very important screening tool, and it's quite costly, it's expensive. So what is the situation in terms of cancer, breast cancer prevention and early detection in Ghana? Do you have any statistics on the rates at which you are detecting it? And Dr. Owusu talked about the ages of screening here in the United States. And you gave us a very interesting statistic that you are seeing them more in the age group of 40 and 49. Are you screening people earlier than this age to be able to pick up breast cancer? So if you can speak to these issues for us.
Yeah, so let me first say that we don't have screening mammography in the country. And in fact, no African country has it yet. So we don't have that system. But since we are still seeing a lot of palpable lesions, we advise our women to do breast self-examination. In countries where they are diagnosing non-palpable lesions, you can say that breast self-examination is no more relevant. But in our part of the world, in the low and middle income countries, breast self-examination is very important. The second type of screening we think is very useful, a trained person. So when Breast Care International goes on outreach programs, we go to the churches, we go to marketplaces, we go to the mosques, we go to schools, workplaces. We educate women about the disease, and then we teach them how to do their own breast self-examination. After that, we put every woman down to examine the breast for her. It's only when we suspect something or we find an abnormality that we refer the woman to the hospital for diagnostic mammography. However, we advise our women that between the ages of 40 and 50, they can have mammogram done once every 2 years. But after the age of 50, they should have it every year. So if we are advising them to do their own breast self-examination, we are also advising them to go for clinical breast examination once every year. And then for the mammogram after age 40. It's only when there's a positive family history that we advise them to start the mammogram from age 35. Unfortunately, because our patients are a bit younger, sometimes you person, when you really have a case to worry about, or when you strongly suspect cancer, then you have to use the mammogram. It's not as if we have mammograph machine in every regional hospital. Just last week, the Minister of Health came out to say that in the whole of the northern region, we don't have one single working mammograph machine. And this is unacceptable because it means a woman has to travel for 6 to 10 hours before she can have a mammogram done in either Kumasi or Accra. But that is the truth. And that is why we think that we should continue creating the needed awareness, provide the machines where necessary and when we can get people to contribute, and also come to the aid of the woman. After all, if you go for an outreach in her village and you find out that she has breast cancer, what do? Do you leave her there, or you have to then help? I was listening to the work that Susan G. Comey is still doing in the US. I think we have reached a point where we have to have such social support systems in our country. And that's exactly what Breast Care International Cancer Fund. And for women to access it, those who need it for some financial support for mammogram, for biopsy, because core biopsy is very essential and very, very expensive. Mammogram costs between 150 Ghana cedis and 500 Ghana cedis, depending on where you are going to have it done. And a few Ghanaian women can afford that. So, and that is not for screening mammography. That is mainly for diagnostic mammography. And so the situation at hand, home, is quite different. And let's not forget that the Ghanaian woman is faced with a lot of barriers. And the myths and the misconceptions surrounding breast cancer are enormous. People think it's an incurable disease. They think it's caused by witchcraft. They think it's a spiritual disease. They think women die out of mastectomy. And they think that it's a curse on a family, especially when there's a positive family history. And because of all these, breast cancer is still stigmatized. So some women do not even want to tell anybody when they found something in the breast. And that's why the awareness creation is so critical. But the woman has to be looked at, critically. What are the barriers she has to overcome to even access breast health care? The lack of awareness is huge. I've mentioned it. Inadequate or bad treatment, especially if she's in the rural community. The cost involved is so high, the distance, and all the treatment centers are in the cities. So if the woman is not in the city, she has to travel several times. The lack of counseling, and it's not every cancer treatment psychologist available, and the woman is diagnosed with breast cancer. What happens? She just leaves the hospital and doesn't want to go back again. The lack of support, to the extent that some husbands are even divorcing their wives because they've been diagnosed with breast cancer. And that is very unacceptable. The level of poverty is still high, and the fear surrounding breast cancer is huge. And that is why we brought in the breast cancer survivors. When we had some research, in-hospital research, we came across the fact that we had these figures that more than 70% of the patients ran away from mastectomy. They just don't want it. About 22% ran away from chemotherapy. They don't want to lose their hair, they don't want to change color, and so on. So we needed to bring in the breast cancer survivors to empower them. And we had a survivor from Caris Touch in California, who came to help us train our survivors to peer navigate their fellow Ghanaians. So whenever the patient, someone is diagnosed early, the first day, she's given to a breast cancer survivor. And the survivors share their stories. We have the project called Hope, helping others through personal experience. And so they navigate them through their cancer journey, and they actually are forced to reckon with. With the help of these breast cancer survivors, we are able to get more patients to accept the treatment that they need. And also, the research we did opened our eyes to the fact that we need to offer the needed treatment modalities to our people. And so we started to educate them about the fact that if you come early, then we can do breast conserving surgery for you. And so among the survivors, we have those who have survived through breast conserving surgery and those who underwent mastectomy. But of course, because breast conserving surgery has to be followed by radiotherapy, and the cost of radiotherapy these days is very high. So a lot of patients are not able to pay. So if you do breast conserving surgery for her, and if she's not able to pay for the radiotherapy, it means you've done no job. So we always have to find out whether the patient will be able to afford the cost involved in radiotherapy. And radiotherapy is offered in 2 centers, Korle Bu and Komfo Anokye. And you can imagine the kind of queues that normally they have there. So breast cancer patients have to go through a lot in Ghana. And when you listen to the opportunities that exist in the developed countries, and some women are not even taking advantage of it, it just goes to buttress the fact that when people have it, they don't appreciate it. I wish our women had the opportunity to get the free mammogram, the free biopsy, the free CT scans, and the surgeries and the treatments that they need. We are just trying to get money into the breast cancer fund that we will be using to assist breast cancer patients and survivors who are vulnerable. We have the BCI America as a 501c3 organization duly registered in the US. So our friends can go to the website and also contribute their quota into the fund so we can use it to help our women back at home, and men, because our men also are getting breast cancer. And the overall incidence is on the rise among women. And we are seeing more men also coming on board. So we need to do more research. And I talk always about research that we are not doing, because we don't have any research funds that you can apply to and get money to do something. And so I'm inviting our colleagues, friends in the US and in Canada, in the diaspora, to come down. Let's do the research here. We have the materials. Let's see the trend in our women. Why do we have women being diagnosed so early? Our youngest patient is a 13-year-old girl, and she had phylloides tumor, bilateral, which is very uncommon. And so we had to do bilateral mastectomy for her. Otherwise, she was going to die from the right breast phylloides, which was already intermediate. And so the situation at hand is there, and we need all hands on deck. I want to invite you, our brothers and sisters out there. Come, let's work. Let's help our people. Come out with the trend. The reason why are we having so many triple negative disease? And through the Ghana Breast Self-Study, ours was about 38% of triple negative. And grade 3 tumors are so common. So awareness creation should be intensified so we can get patients with early stage disease and reduce the number of women dying prematurely, painfully from breast cancer. Thank you.
Thank you so much. That was very extensive, and I think it answered some of the questions we had in our WhatsApp chat, and also some questions that we had in our chat here on as well. So, so just do statistics of male breast cancer incidence in the United States as well, just to have an idea that our men should also be taking care of this.
Okay. So male breast cancer is not as common as female breast cancer. If you remember, I mentioned that in this year, 2020, 270,000. 2020, 2,700 will be diagnosed with breast cancer. So it's like 1%. However, male breast cancer is more aggressive. When a man gets breast cancer, he's more likely to die than a woman. And so when a man gets breast cancer, it's taken very seriously. One of the biggest limitations when it comes to male breast cancer is because the number of people getting male breast cancer is so small, there hasn't been any studies, research, meaningful research in males with breast cancer, because you normally need a large number of men or people to be able to do research. And so all the treatments and guidelines that are applied to men is simply fashioned after what has been developed in women. And so male breast cancer is treated almost the same as female breast cancer with a few differences. So it's not common. There's no screening for routine screening. There's no routine screening for males. However, if you find, normally what happens is you find a lump in your breast, and then you go off to your physician. Then you get a diagnostic mammogram and a biopsy they think is suspicious looking. And usually that's how a man is found with breast cancer.
Thank you. Thank you very much. So my last question on this will go to Dr. Montgomery. So we've been talking about all these barriers, and we've been talking about awareness creation and everything that will make people see the need to prevent breast cancer. My question for you is, how has the prevention message been received, especially in the minority communities? And with that, we want to talk about the African American community.
Thank you. And I want to pick up on a couple of things that Dr. Owusu and Dr. Viafi were saying, because I think it's directly relevant. So I'm troubled to hear what's going on in Ghana, but I have to also say that for Ghanaian women immigrants, there are similar anxieties and barriers and hesitancies to seek treatment and to engage in prevention. So our audience are a lot of American immigrant women from Africa, and I want to implore you that you're a very vulnerable population because A, you have a genetic predisposition and pattern that follows you from Africa. In the United States, Black women as from breast cancer, they used to have less breast cancer, but it has increased. So the prevention message is getting out there. And I have to say that when I first started many, many years ago, it has increased significantly. Susan B. Komen was mentioned, a lot of breast cancer prevention organizations. I think Navigators has been an incredibly effective model to actually reach out to the community and have survivors share their story. Because there's nothing as powerful than to share what you yourself have gone through. The fact that whatever anxieties you have about losing your partner, your spouse, your family members not being accepted anymore, double and triple difficulties with prevention, because it is such an important part of identity for Black women. And when you then add the issue of being exposed to endocrine disrupting chemicals through the very beauty products that make you beautiful, it becomes even more tragic, I think. Because here are women who take a lot of identity from their breasts. In general, women do that. And then you add that we as a society want women to look a certain way, and therefore the very products that they use to make themselves more attractive in their relationships are products that put them at increased risk. So I'm delighted to say that in the years that I've done outreach work, I have increasingly seen that Navigators have been critical, that the Black community has stepped up, that churches have stepped up. And I think we need to continue sharing this message and sharing it also with our African immigrant community. I also believe that with the evidence increasing, that beauty products here are now increasingly proven to be a part of that unknown. Why are breast cancer rates higher? We are beginning to chip away with research on the unknown. And we are learning that these products, these beauty products, are very important to be avoided. So there's a lot of outreach that needs to go out to the community about the bleach for the skin, the deodorants, the beauty products that are used in hair, and the early exposure. So if you look at young women, Black women in the United States, they start their beauty regimen very, very early. And their exposure to a lifetime to these EDCs are much longer and much heavier in dosage than any of the white women. I'm delighted that from a prevention perspective, when we talk about this in churches, that people are very engaged and very interested. I can tell you, I'm white, I'm a Caucasian woman, but people came to me because they were interested at the time, 6 years ago, that in California, no advocacy had been done around these hair products and beauty products, personal products, but they had heard that on the East Coast there was more work being done. So I think the Black women in particular are becoming more open and more interested and engaging, and they're actually driving the engagement in prevention. And they're doing that through Black women's organization, through churches, and through a lot of research that is actually occurring into this non-genetic component that seems to also significantly contribute to the much higher rates of breast cancer in Black women. So I'm actually delighted to hear that, but I feel we need to keep going at it, we need to continue it. I'm delighted to hear from Dr. Cynthia Owosso all of her insights, and it's this kind of sharing that we need to do with the community. We know Black people are more likely to be connected to churches. So let's use our churches to reach out and share this message about where these risks are. We can't do very little about the genetics, except that we can be aware and screen. That's a big insight. That we put aside these anxieties, these fears that many women have about actually getting diagnosed and what to do then. Then to actually preventively start early with our daughters, to not burden them with these EDCs by having them use products that actually make them more likely to be sick in the long run. So there's a lot we can do. I'm really, really happy to hear that a lot of Black colleagues of mine are very active, and that the movement to find out more and to do more research in prevention and in community education is thriving.
Thank you so much, Dr. Montgomery, for these insights. I'll be handing over to Elder Carlson Safo to just take us through the rest of the program. So we thank you very much for all the insights that you've talked about and you've shared with us. And we want to encourage all of our listeners and viewers to keep sharing the messages on WhatsApp and also the chat here on Zoom. Thank you.
Thank you very much, Dr. Nate. As we are coming to the later part of our program, I know we've taken so much of your time. I'll just want Mrs. Zelma Draper-Brown to share with us. She prefers to call herself a thriver, and I would want her to take us through the treatments that she got, that she received, and what is it that she's going to say about the clinical trials that she's been involved in. Just if you can share with us, we'll appreciate that.
Well, certainly I can share with you, but because I do know that we have a Christian audience, I have to say there's a verse in the Word of God that says that we are afflicted so that we can help others in their affliction. And the information that you all have given today, I believe that I was invited here for another purpose, and that was to get the information that you all have given me, because I am totally blown away when I think about my sisters in Africa, when I think of my own personal struggle. And then I've had the benefit of course, good care from University Hospital and from Dr. Owusu personally. But the thought of my sisters struggling because of all the factors that have already been named, I just feel compelled that because of the many resources that we have in the United States, this is a message that needs to be elevated. And so I hope that my place here today was to help elevate what can be done with all of the resources that we have in the United States so that we can help our sisters there. And I'm so grateful to hear about the program called HOPE, that there is something already being done that we can work with. So I just feel that I am compelled to say that before I talk about myself. I do want to say that I was also, my family was blessed with my daughter actually benefiting from the program that Patrina was talking about, because there are some risk factors that we've learned here today. And so my daughter actually has been walked through the programs that University Hospital has for those who are uninsured with Patrina, and extending the services so that we could check out some things that were troubling in her life. So I did want to say that. So it is great to have that kind of community support. And so I said that so passionately, I'm not quite sure, struck me
yes.
To my heart about my sister struggling across the water. So what am I supposed to be, what question am I supposed to answer?
Share with us what kind of treatments that you got.
And yes, I do know about the treatments, because actually beside a full mastectomy, I had chemotherapy, I had radiation, and I had a lumpectomy. So I was grateful, very grateful, and I think this is one of the things that we do have to share as survivors and thrivers. And I say thriver because I was able, when I was diagnosed, that I did let my church family know, and that there were many people that prayed for me. And I do believe it was the prayer of the righteous that availeth much, because I have to say, I never stopped working. I never lost my appetite. I never lost a night of sleep. I never got sick from any of the treatments. And I also have participated in 3 research studies because I do know that African American women do not participate that often in studies. So all of the studies that were offered to me, I participated in. So I am grateful because I feel like if my journey can help someone else, and that is why I feel so strongly about the information that you all have shared today, that I'm here because that the Lord has taken me through this so that I could help someone else. So yes, I like to share that. I do say to all of the survivors that we are thrivers when we make it to the other side, because we have not only gone through, but when we've made it to the other side, then we have the gifts that we have learned today can be the launching of continuing to help not only my sisters here in the United States, but there's many resources to help the sisters here in the United States, but that I can help some of my sisters in Ghana. Because one of the things that I would say is critical that I had written down on the questions, and that is support. Because I, as you heard, my background is social work, and so I was that person that went to the hospital with everybody else to support them. And I have had many that I've supported. My parents, friends I have supported through cancer journeys. And so I was that person. But when it came to me, then I realized that the thinking that I had was no longer adequate, because when someone gives you a cancer diagnosis, you cannot think clearly as you did before. And I learned there was such a thing as chemo brain. And I realized that there's issues of grief and loss and all of these things that impact your thinking. So a support system is critical. And Dr. Owusu will tell you, every time I showed up, I had an army with me of support. So I understand that my sisters who in Ghana, how important a support system would be for them. But if they are not sharing, then they can't have that support system. And truly, 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 I do believe it was the prayers of the elders in my church that said they were calling my name daily before the Lord. That was as important as the chemotherapy, as the radiation. And I am on the anastrozole, which I am starting to take now. And there was one other thing. Oh, I know. I also had a great Christian when I would go for my chemotherapy. It was a sister who was also a Christian. And she said to me when I was trying to make a very important decision of whether to continue to take a medication, she reminded me that I was living for the Lord. I was not living for cancer. And my point in saying that is that as a thriver, I wanted to do everything I could as far as health to live, but I also knew that God has a purpose for my life according to the word of God. He said he has prepared in advance good works for us to do. And so I praise God and I thank you that you all have allowed me to have this time today. And I hope from the information that I've heard that some of my good works will be able to continue in helping my sisters in Ghana. Thank you.
Thank you, thank you, thank you so much, Mrs. Zelma Trepa Brown. We are praying that the good Lord will perfect his healing and will not hear this kind of news anymore. I want to thank you all. I mean, everyone that has been here joining us would know that indeed we have been impacted in a very, very, very huge way We've had wonderful panelists who have shared their wealth of experience with us. The opportunity to share their parting words so that, as we go, we can have that. So I would want to start with Dr. Susan Montgomery. I would want you to share your parting words with us.
I kind of shared my parting words also in the chat. I think that it is really important for us to share. I want to agree with the person who last, Zelma Brown, who just last talked. I believe that sharing and being a larger community that serves the purpose of taking care of their members, including not just their spiritual, but also their physical health, is critical. Yes, breast cancer is a scary issue, but we have learned a lot to treat it. But in many respects, there's a lot we can do to also prevent it. And the nice thing that we can do to prevent it is that it's the same across breast cancer and across as well prostate cancer. So it's a family issue. And Black community, African community is all about family. So healthy living, in addition to being aware and being connected to a community of faith and a community that helps us with our stress, all of these things come together to make us healthy. So yes, research is important. Yes, medicine is critical. Having people like Dr. Cynthia is wonderful. And they are so knowledgeable and they can help us once we get there. And we have gotten much better in the treatment. But there is so much we can do about prevention if we help each other in our family, with our men, with our women, and with our children. Look at the simple recommendations that are out there. Limit your alcohol, no tobacco, eat healthy, watch your weight, exercise. Those are things that all of us can do. Be in a community of faith. Get your support. Reduce your stress, manage your stress. These are age-old recommendations, and I'm so thankful that they started in the Bible, they continue in our faith, and we can make them happen in our daily lives.
Thank you so very much. Just before I continue to allow you to give your parting words, I want to give the opportunity to some of those who are our viewers and our listeners who have questions that they want to ask. I've seen that Gideon Osei is sending a message. Gideon, I don't know if you'd want to unmute and ask it, or you just want us to go ahead and read what you've said. Gideon, you can unmute and ask your question. Okay, so he's asking, was there anything about food that our powerful women was asked to cut down or stop eating during the management? Or, that is to the panelists. He wants to know whether there's any particular kind of food that we are asked to stop eating or minimize, reduce. So, Dr. Yeah, go ahead.
Well, I can say personally that I did a lot of reading. And so as soon as I was diagnosed, the main thing that I tried to do a good job of was cutting down sugar, cutting out the sugar in my diet. And of course, everybody knows about the fruits and the vegetables. I never was a huge meat eater, but I still do eat some meat. So what I would do is all of the time so that I could start to make the healthy lifestyle changes that were recommended. So I didn't have really bad health before I was diagnosed. I wasn't on any medication prior to being diagnosed with cancer. But I knew that diet would impact my health. And so I really started to just do what everybody is recommending for all health issues, is more fruits, more vegetables, and really cutting the sugar. I'm not doing as well as I could with my drinking of water, which I know is very significant, and cutting the sugar. Those are areas I still have to work on. But one of the things that I do know is progress is always good. And so that was the main thing that I did.
All right. Dr. Cynthia, do you have something to add to it?
I think Ms. Draper Brown has nailed it on the head. And I think our Seventh Adventist teaching, the teaching that we've gotten from Ellen G. White, is right on target. Plant-based food, we all know that, but we don't want to do it. More fruits, more vegetables, less red meat. Dr. Montgomery has mentioned alcohol. Yes, so drink more water. And I want to say that a lot of us, we wait till we have cancer, then we want to change our diet. Really, for the maximum impact, it's a long-term benefit. So you really need to start early. Start now. Start now, everybody, all of us. Start now. Let's exercise. Let's eat a healthy diet. Let's lose weight. Obesity produces a lot of hormones which cause breast cancer and other cancers to grow and to start off. So let's try and lose weight as well.
Okay, so I don't know if there are no other questions on the charts, but I don't know, I'm going to give 10 seconds to anyone who wants to unmute and ask a question. If you have a question, you can unmute and ask.
I did see that question that someone asked about, could someone speak more about the hair products? I saw that earlier, and I don't know whether it was missed, but there was a question about the hair product.
One of the issues, and this could be an hour or two by itself, but what I can do is I can share some resources. There's overwhelming evidence, and I think at this point in time, people believe that we have a very strong link between the exposure to health and beauty, personal care and beauty products. There's endocrine disrupting chemicals that are part of what the beauty product calls, they don't put them on the label. So it's very difficult to see what you actually are putting on your hair. They put it under fragrance. So what is happening that a lot of these beauty products that are put in to help make the hair more manageable, to make it softer, are actually culprit in breast cancer genesis. So we do know that the softener, hair softeners are particularly implicated. We do know that if you color your hair dark color, out of all things, again, you think about who gets breast cancer more likely, Black women, dark color is actually more implicated. So there are certain types of hair products that have a higher risk ratio, but we do know that in general, beauty products and personal care products actually increase the likelihood. Now, I want to come back to what Dr. Cynthia was saying, that anything that you put in that is hormonal, whether you're male or female, and that you take over time, increases your risk. So yes, even if it's through your hair or your body, you can increase your risk. But it also is whatever you put in as you eat and as you digest. So it's a complicated story, but I think the evidence is out. And I think as a woman, I have increasingly stopped using certain products. And it's much tougher for Black women who have a lot of expectations in this society on how to be attractive to stop using these products. But it's an empowering issue as well. And I'm delighted that my sisters are increasing using their hair natural, or choose other types of styles that are not necessarily requiring use of products.
Thank you very, very much. Okay, Dr. Cynthia Owusu, please, can you give us your parting words?
I think my parting words are really no different from Dr. Montgomery's. In cancer, the best option is prevention. Prevention, prevention, prevention. please put people like me out of work, because you only come to me when you are diagnosed with cancer. We don't want you to get cancer. Prevention, prevention, prevention. So all the things that we've mentioned about a healthy lifestyle, and also get your mammograms. And I know it's unfortunate that in Ghana, they don't have that option. I almost fell out of my chair when Dr. Wiafi said that. So my other message, and I concur with Ms. Brown, we really all need to go to Ghana and help out. In this present day and age, there should be no woman under the surface of the earth who cannot get a mammogram. I'm blown away by that, because mammograms save lives. If you have stage 1 breast cancer, that's what mammogram can do for you. They are able to catch it very early. Your survival is almost 99%. Breast cancer then just becomes a bump in the road for you. You get your treatment and you move on. That's what mammograms can do for you. So we all need to put our resources together and head down to Ghana and help. That's my other second message. And with that, I will stop.
Thank you very much. Thank you very much. Okay, so Dr. Wiafi Adai, I would want you, because, I mean, and Cynthia just ended with Ghana's situation, so I'd want you to give us your parting words too.
Thank you so much, and I want to thank Auntie Cynthia and our cherished survivor and our other panelists who have shared our plight. Someone asked whether there are business opportunities for people who want to open up mammography centers. Yes and no. There are no restrictions. But before you buy a machine to maybe, let's say, Sefi, you have to make sure that we've done enough awareness exercise there. We also have a system that we can help those who need to access the services. Because if you buy the machine there and people are not able to pay for it, then you know it wouldn't be profitable. So yes, let's put in more effort. What we are going through now, I think, is a phase that we need to go through in order to develop better. But and the US passed through this same phase some time ago, way back. We don't need to reinvent the wheel. We just need to fall on best practices and do the things that need to be done rather quicker. We need to run and not crawl anymore. So if we are able to educate our people more, we are able to create more awareness, teach them what to do, and assist them to get the treatments they need, we will by all means save a lot of lives. And I always say we still have room for research. Let's come home and let's do the research that we need, which will bring up a lot of issues and how we can solve them so that we can, change the narrative. Enough of all those negative things. We should move faster than we are doing now and change the narrative with your involvement. Thank you.
Thank you very much. Thank you so much. Ms. Petrina Peterson, your parting words for us. I believe that you're reconnected now and you can be able to.
Yes. Yeah. Hopefully you can hear me. Can you hear me now?
I can hear you better.
Okay. I had to go through the phone instead of my computer for some reason. It wanted to act up, I guess. But my parting words is, first of all, just thank you. This has been a powerful, almost 2 hours of talking about the needs of women and also mentioning our brothers who can also have breast cancer. But definitely find that person like Zelma that you can talk to, get a navigator, check into your resources, especially here in the United States. I am heartbroken with hearing about Ghana, and also I had the same experiences that my sister talked about when I went to Guyana in South America. They were suffering with those same issues, and the death rate is high for women with breast cancer. But here I shouldn't say here in Cleveland, but there in California, like I said, I'll be happy to send these resources to Dr. Wusu, who can send it to our participants, to our organizers. And if there's anytime you have a question, you can always get to me through Dr. Wusu. She has all my phone numbers and my email. And anything that I can try and research and try and navigate through the system to help women get a free mammogram. Thank you so much for your time today.
Thank you, thank you, thank you, thank you. Thank you so much. On behalf of our viewers and our listeners, I want to say thank you to the wonderful panelists that we've had. It's been a wonderful time with you. And, I'm so excited when I see powerful women, because I believe that women rule the world and you can do it better. So I'm so happy that you were able to spend so much time with us today and in helping us to understand this issue of breast cancer. We are so grateful to you for your time. I would want to hand over to Dr. Kwame Agyeman, who is the president of United Service to Africa. I'd also want to say a big thank you to the Riverside Ghanaian SDA Church, because they have helped, together with United Service to Africa, to bring this program to life. And we are really grateful for the opportunity that the church has given us to be able to do this. Dr. Kwame Agyeman, over to you.
Oh, thank you. It was such a chilling experience. 4 years ago, a great dear sister-in-law of mine passed away of breast cancer at the age of 48. It was a sad story. I hope you will do more for our brothers and sisters on the continent. On behalf of United Service to Africa and Riverside Ghanaian SDA Church, I would like to thank all the panelists, Dr. Cynthia Wusu, Mrs. Zelma Brown, Mrs. Peterson, Dr. Montgomery, and Dr. Beatrice Yafi are there. I believe probably we need to have part two. There's a lot that we couldn't talk about. I believe we need to have part two. We also want to thank all the participants that are on here, spend their time to be on Zoom for the past 2 hours. Those that are watching on Facebook, those that are watching on Obra TV, those that are here on Radio Ghana in Italy, Europe, and those that are also listening on Yonkodo Radio or Taibo channel, and as I saw Obra TV of USA. We thank you all. Thank you, Mr. Kesson Safo and Dr. Nathaniel Agyeman. He has to catch up a flight, that's why he left. Thank you all for moderating this great event. Also, we want to thank Mr. Emmanuel Mensah. He is the IT Director for United Service Africa, for helping us with some of these webinar series, putting together and managing behind the scenes. It has been 1 week breast cancer awareness celebration, started with a walk. That's why I got my medal. And then we had the prayer on Wednesday, we have Rest Fest Friday, and yesterday also we had a very extensive second pink worship service. And then also Dr. Poyebua gave us the what we've been talking about our diet, the role of diet in breast cancer prevention. At this time,